Hello future doctors, I am Dr. Shoham Mukherjee and welcome back to my channel. Are you ready to crush the subject PSM like never before? Today in this video I am going to have a ultra rapid revision of PSM in just 11 power packed pages. In just 11 pages, you heard it right. PSM is a very big subject, it is very volatile and will carry more than 30 to 35 marks in your upcoming exam. So whether you are preparing for FMG or NEET PG, this video will help you a lot. It will help you save your precious time to do rapid revision for hours. Also, it will get you correct more than 90 questions in the exam and it will help you get over this boring subject. This video is smart, sharp and exactly what you need in your final stage just before the exam. So what you need is just download the notes from the link given in the comment box, hit the like button, subscribe to my channel and let's dive into the fastest and most effective PSM rapid revision ever. Also, you can join my Telegram study preparation group. The link for that is also given in the comment box. For any queries, you can reach out to me on Instagram or you can provide your queries or doubts in the comment box only. So let's begin. Let's make every second count. Your rank starts now. Let's go.
Our first topic is National Immunization Schedule. So the minimum gap between the two vaccine doses should be 4 weeks, and if it is live vaccines, it should be 3 weeks. According to the National Immunization Schedule, these are the various time periods when we should provide the following vaccines to the children, and you should expect at least 1 to 2 questions from this topic. Okay, so at birth, what are the vaccines we should give? The first vaccine we should give is BCG, and BCG is given once in a lifetime. Okay, if we miss at birth, we do not give BCG again. And then is oral polio vaccine 0 dose, hepatitis B birth dose. Small b is the birth dose. Hepatitis B birth dose is given at birth and it is given only after 24 hours. Okay, after 24 hours it's not given. So BCG once in a lifetime, OPV oral polio vaccine 0 dose and hepatitis B birth dose. Then comes the 6 weeks. 6 weeks we give pentavalent 1, oral polio vaccine 1, rotavirus 1, IPV means inactivated polio vaccine fractionated 1 and PCV, okay, pneumococcal vaccine 1. These are the vaccines given at 6 weeks. At 10 weeks given are pentavalent 2, OPV 2 and rotavirus 2. 14 weeks pentavalent 3, OPV 3, rotavirus 3, IPV fractionated 2 and PCV pneumococcal vaccine 2. 9 to 12 months, this 2 means the second dose. 9 to 12 months the given are measles containing vaccine, the first dose measles, mumps, rubella or measles, rubella. Pneumococcal vaccine booster dose, Japanese encephalitis, if it is in the endemic area then it is given. IPV fractionated 3 and vitamin A prophylactic dose is given. Okay, only the prophylactic dose, the first dose is given at 9 to 12 months. The second to 9th dose are given every 6 months till 5 years of age. So how many are the total doses? Total doses are 9. First dose at 9 to 12 months, second to 9th dose every 6 months till 5 years of age. What will be the dosage? First, if the age of the child is less than 1 year, the dose should be 1 lakh international unit, and if it is more than 1 year, the dose should be depending on the body weight. If it is less than 8 kg, again it will be 1 lakh international unit per dose, and if it is more than 8 kg, it will be 2 lakh international unit per dose. So these are the doses of vitamin A. At 16 to 24 months, we should give oral polio vaccine, then the booster dose. This capital B is booster dose. This small b at hepatitis B is the birth dose. Then DPT B1, MCV2 and Japanese encephalitis the second dose. At 5 years, we give only DPT B2. At 10 years, we give TD and 16 years TD. Okay. For pregnant women, TD1, the first dose is given early in the pregnancy. TD2 is given 4 weeks after we give TD1. We have already discussed the minimum gap between two vaccine doses should be 4 weeks. And TD booster doses is given if pregnancy occurs within 3 years of the previous pregnancy and both the TD doses were received. Then only TD booster dose is given after 3 years. Okay, if pregnancy occurs within 3 years of the previous pregnancy, so the first pregnancy we have given both the doses, and within 3 years the next pregnancy occurred, then we give the booster dose. Now coming to the various adverse effects of the vaccines. For OPV, the adverse effect is vaccine associated polio paralysis. BCG, the adverse effect is miliary tuberculosis. For hepatitis B, it is anaphylaxis. For DPT, it is high grade fever more than 40.5 degrees Celsius. And what we will do? We will replace the whole cell pertussis by acellular pertussis. Okay, DPT, diphtheria, pertussis, tetanus, we will replace the whole cell pertussis by acellular pertussis. And also there will be inconsolable cry. Inconsolable cry means the child will cry for more than 3 hours. We cannot control the cry. there will be anaphylactic reactions and also active neurological disease. If such things happen, if we find these symptoms, the next dose is contraindicated. We will not give the next dose. For TT, the adverse effects will be anaphylaxis and brachial neuritis. For rotavirus, it is intussusception. For measles, it is toxic shock syndrome. For MMR, it is thrombocytopenia. For influenza, it is Guillain-Barré syndrome. And for varicella, it is febrile seizures. Now comes to open vial policy. What is open vial policy? Suppose you are using one vaccine and you are keeping the partially used vaccine for the next session, and it should be a multi-dose vaccine, okay? Then we will follow the open vial policy. So it is the reuse of partially used multi-dose vials for next session up to 4 weeks, up to 28 days to reduce the vaccine wastage, okay? What are the conditions? Means what are the things we have to keep it in mind for using open vial vaccines? The expiry date should not be passed. It should be stored in appropriate cold chains. Vaccine vial should not be submerged in water or it should not be contaminated. Aseptic techniques should be used to withdraw the vaccine, and vaccine vial monitoring not reach to the discard points, okay? So we have to maintain that it has not reached the discard point. Stage 1 and 2 are used, stage 3 and 4 in the vaccine vial monitor are not used. And this vaccine vial monitor policy is applicable to the following vaccines: DPT, TD, OPV, IPV, PCV, hepatitis B and pentavalent. You have to remember all these vaccines in which vaccine vial policy, open vial policy is applicable, and not applicable to BCG, measles or measles containing vaccines, Japanese encephalitis, Covishield and Covaxin. So the COVID vaccines, BCG, measles, Japanese encephalitis are not applicable with this policy. Now coming to the strains of vaccine. For BCG, the strain is Danish 1331. For measles, it is Edmonston Zagreb. For mumps, it is Zerilin. For rubella, it is RA27/3. For yellow fever, 17D. Chickenpox or varicella, Oka strain. You have studied all this in microbiology also. Still, I am revising once again. For polio, OPV, it is P1, P3. And IPV, it is P1, P2, P3. Earlier, OPV was also P1, P2, P3. But on 25th April 2016, it has been switched. It is known as the switch day. It has been switched to bivalent, okay? From P1, P2, P3, it has been switched to P1, P3. P2 has been omitted. Why? Because the adverse effect it was causing was vaccine-associated polio paralysis. So we have to remember the switch day. It is 25th April 2016. For dengue, it is CYD-TDV. For rotavirus, it is R1X4414. Japanese encephalitis. For the live ones, it is SA14412. And for killed one is Kolar and Nakayama. These are the name of the vaccines. Kolar is for India and Nakayama. Now coming to various morbidity indicators. So morbidity indicators are incidence and prevalence. First we'll understand what is incidence. So incidence are the new cases, okay? What new cases are happening, that is incidence, new cases of the disease. And it is studied by cohort. Cohort study is done for incidence. It requires further follow-up in the future. The denominator in this cohort study will be the population at risk, and it measures the rate of the occurrence of the disease. So incidence is the rate of occurrence of the disease, and we will understand the new cases through incidence. It does not depend on the duration of illness. So incidence, however long or short the duration is, incidence will not vary with the duration of illness. What is prevalence? Prevalence is existing cases, means the old and the new cases. All the existing cases come under prevalence. It is studied by cross-sectional and no follow-up is required. No further follow-up is required. The denominator here is the total population, not only the population at risk. Population at risk was the denominator for incidence, but here it is total population, and it gives the proportion of the diseased person, not the rate. It gives the proportion of diseased person. It depends, okay? It depends on the duration of illness. So the opposite of incidence, it will depend on the duration of illness. So these are the morbidity indicators, incidence and prevalence. Now coming to the mortality indicators. The mortality indicators are crude death rate. Crude death rate, here the denominator will be mid-year population, and it is not age or sex specific. But specific death rate, in specific death rate, it will be age or sex specific. Like suppose a particular age, male or female. So it all specific death rate will be dependent on this age and sex, and it will. By this, we will understand the risk of death in different groups because it is age or sex specific. So different groups, risk of death we will understand by specific death rate. What is proportional mortality rate? It is deaths due to all the causes. So the denominator here will be deaths due to all causes, and it will indicate the burden of the disease with respect to mortality. The burden of the disease with respect to mortality, the denominator is death due to all causes and the numerator is death due to the single disease. So death due to specific disease by death due to all causes. So that is the proportional mortality rate, and it will identify the most common cause of death. What is case fatality rate? It will indicate the virulence or the killing power of the disease. The formula is death by cases. Age standardized death rate. It is used to compare mortality between two populations of different ages. Age standardized, in the name only you can understand, it is used to compare mortality between two populations of different ages, and it is calculated from direct standardization. And standardized mortality ratio, it is used to compare mortality pattern between occupational and general population. Occupational population means, suppose coal miners, we have to compare coal miners or aluminium factory workers with the general population. By that we can understand that how the occupational workers are affected with respect to the general population, what is their mortality, and it is calculated from indirect standardization. So I hope everything is clear in the mortality and morbidity indicators. Now we will move on to the indicators of the quality of life. So first one is physical quality of life index, PQLI. What are the components? You have to remember only the components. The components are for PQLI, life expectancy at 1 year of age, literacy rate and infant mortality rate. How will you calculate? It is calculated with the help of arithmetic mean or the average. Then comes human development index, the most important one, HDI. The components are life expectancy at birth. Here it was 1 year of age. Here it is birth. Knowledge means the mean year of schooling and the expected year of schooling. And then income. So 3 components. Here also 3 components. And we will calculate HDI with the help of geometric mean. But here PQLY was calculated with the help of arithmetic mean. Global hunger index. The components will be undernourished population, underweight children in the age of 0 to 5 years and child mortality in the age of 0 to 5 years. Multidimensional poverty index, it includes education, means the school attendance or the years of schooling, health, child mortality, nutrition, child mortality between the age of 0 to 5 years of age and nutrition of the child. Living standard includes various facilities like water, electricity, fuel, house, sanitation, if these are provided or not. So these are the various indicators of the quality of life. Natural history of the disease is best studied by cohort. Okay, why cohort? Natural history is best studied by cohort because follow-up is done in cohort. We have already studied follow-up is done in cohort. Level of prevention in pre-pathogenesis phase is known as primary level. Prevention of disease in the presence of causative agent. Okay, pre-pathogenesis, before the disease happens, primary level, and the prevention is done in the presence of causative agent. Ability of an agent to produce the illness is known as pathogenicity. Communicability of the disease is expressed by secondary attack rate, how much the disease is communicable. Hidden portion of the iceberg doesn't include the healthy population. Hidden portion doesn't include healthy population. And what is the most dangerous area? The most dangerous area is the submerged area. Subclinical cases. Okay, diseases showing, or like what are the diseases which show the iceberg phenomena? HIV, malaria, typhoid, cholera, diphtheria and polio. And what disease does not show iceberg phenomena? Rabies, tetanus, pertussis and measles. So diphtheria was included in the disease which show iceberg phenomena, and remaining 2 in the vaccines like the tetanus and pertussis does not show the iceberg phenomena. What is HALE? Health adjusted life expectancy. It means life expected to live in healthy state without adjustment. So it means the number of years we are living in our healthy state without doing any adjustment. It is the best indicator of disability. What is QALY? It is quality adjusted life years. It means the life lived in healthy state with adjustment. Here we were living without adjustment. Here we are living with adjustment. If with adjustment, then it is quality adjusted life year. And DALY, disability adjusted life years, it is the years lost in life due to disability. Suppose due to some accident, you have some lost, the person has died. So how many years the person was expected to live and he has died some years before. So that are the years which were lost in the life due to disability. Years lost due to premature death. 1 DALY equals to 1 year loss, and it indicates the burden of the disease. So these were the various health indicators and some one-liners which we have discussed. Now coming to the difference between case control study and cohort study. Earlier we have discussed that we will calculate with the help of cohort and case control. So what is the difference between them? Case control study will proceed from effect to cause, from the result to why the thing happened. Then cohort study will proceed from cause to effect. Case control study will compare exposure between cases, the diseased pupil versus control, the normal pupil. And cohort study compares incidence between the exposed and the non-exposed. Case control is a retrospective, means it will go backward, retrospective, and cohort study may be prospective or may be retrospective, so it can be either of them. And it will compare exposure between cases versus control. So if exposure is more in cases, the odds ratio will be more than 1. If exposure is more in control, the odds ratio will be less than 1. You have to remember both these points. And so normally it will be calculated with the help of odds ratio. It is quick to conduct, it is inexpensive, it is suitable for rare disease, and recall bias is seen because it is moving from effect to cause. So when we are trying to remembering the cause from the effect, when we go back, when it is retrospective, there is problem in the recall. Therefore, recall bias is seen in case control study. Cohort study, it will be prospective or retrospective. It is time consuming, it is more costlier, and it requires a large number of subjects because we are comparing the incidence between the exposed and non-exposed. Therefore, large number of subjects are required. Such subjects may drop in between, so there is loss of follow-up and it leads to attrition bias. Here there was recall bias, here it is attrition bias, means loss of follow-up. And risk ratio, we can calculate incidence in the exposed divided by incidence in non-exposed. So with the help of cohort study, we can calculate the risk ratio. Now coming to a very, very important topic and very confusing one. So let's understand it properly. What is sensitivity? Sensitivity is the number of, you can expect many numericals from this topic, okay, and they will try to confuse you with the numericals in the part 1 of your paper, and it will be very time consuming. So you have to get a clarity of these topics. What is sensitivity? Sensitivity is the percentage of diseased individuals who are currently identified as diseased, and it will give the probability of when the disease is present, the test is positive. This is known as true positive rate. So disease is present and therefore the test is positive. It is known as true positive rate. What is sensitivity? It is the percentage of diseased individuals who are currently identified as diseased. The test is correctly identifying the actual number of diseased individuals as diseased. What is specificity? It is the percentage of healthy individuals who are correctly identified as healthy. Here, diseased individuals correctly identified as diseased. Specificity, healthy individuals correctly identified as healthy. And it will give the probability of when the disease is absent, the test is negative, means true negative. Disease absent, test negative is known as true negative rate. From the name you can see sensitivity, it contains N, and so it will be the opposite, okay, true positive, P is P. Here specificity is contains P and it will be opposite true negative. By this is a small mnemonic by which you can remember it easily. False positive means test is positive but there is no disease. While doing the test we are finding that there is disease but actually there is no disease, then it is known as false positive. What is false negative? Test is coming negative but disease is actually present. Disease is present but we cannot identify it with the help of test. Test is coming negative. Therefore, it is known as false negative because it is actually not negative. It is positive. Disease is present. From the test results, if we are going to see if the disease was present or absent, it is known as predictive value. This term is known as predictive value. If from the test results we are going back to check if the disease was present or absent, and if from the disease we are going to check the test results, suppose the disease is present or absent, and from that we are going to check the test results, so it is known as sensitivity or specificity. What is positive predictive value? It means if the test is positive, what is the probability that the patient has the disease? What is negative predictive value? Means if the test is negative, what is the probability of that the patient does not have the disease? So these are the two terms. I hope everything is clear. What is sensitivity, specificity, false positive, false negative, positive predictive value and negative predictive value. So these were the definitions and easy explanation. Now let's check a diagram. By this you can get a numerical. So here there will be various values and we have to calculate with the help of these formulas. Okay, so let's see what is there. Or if you get a clinical like clinical 3 to 4 lines numericals, you can present it in the form of this diagram. So here we have the diagnostic test results, here we have the disease. Here the diagnostic test result is positive and negative, and again disease is present or absent. So if the test result is positive and the disease is also present, both are positive, then it is known as true positive. If the test result is positive but disease here is absent, then it is known as false positive, okay, because test is coming false but the disease is absent, so false positive. If diagnostic test results is negative but disease is present, it is known as false negative. If test result is negative but disease is absent, it is known as true negative, because both are negative. What is the formula for sensitivity? For sensitivity, I told you it will be opposite. There is n, so true positive by true positive plus opposite of true positive. What is opposite of true positive? False negative. By this you can easily remember this formula. In sensitivity it will be the opposite, so P TP by TP plus Fn. Again for specificity it will again be the opposite, n, so Tn by Tn plus Fp, opposite of Tn. So these were the formulas for sensitivity and specificity. Positive predictive value, true positive by true positive plus false positive, all will be positive. All the things will be positive here. And for negative predictive value, it will be true negative plus by false negative plus true negative. Everything will be negative here. Now one liner, most important factor for a test to be a good screening test. So for a test to be a good screening test, what is the most important factor? It is sensitivity. And again, the most important factor for a test to be a good diagnostic test, not a screening test. If it is a diagnostic test, for a good diagnostic test, what is the most important factor? It is specificity. But screening, it is sensitivity. Now for statistics topic, here are some onliners. To compare mean values between two groups, we use student t-test or unpaired t-test. To compare mean values between more than two groups, we use the ANOVA test. To compare mean values within one group, before and after intervention, we use the paired t-test. So these were the parametric statistics, okay. Now when you are comparing the mean values, it is parametric, and when you compare proportions, it is non-parametric. Here I have written it non-parametric and parametric. So to compare proportions between two or more than two groups, it is chi-square test. To compare proportions within one group before and after intervention, it is McNemar test. You have to remember the names. To check the significance of association, it is either chi-square test of association. This name is known as the chi-square test of association. Preferred measure of central tendency for skewed data, it is median. For skewed data, it will be median. Probability of random sampling, equal and known chance of selection, means if there is random sampling done, what is the probability? There is probability of equal and known chance of selection. Suppose we are from the 100 cheats, we are selecting 20 cheats out of them randomly, then there will be equal and known chance of selection. Sampling technique for non-homogeneous population to ensure proper representation is done through stratified random sampling. So what is stratified random sampling? It is the sampling technique for non-homogeneous population. Non-homogeneous population means from 100 students, there can be 70 boys and 30 girls. How will you properly represent? So from 70 boys, we are taking 7 boys out, and from 30 girls, we are not taking 7, we are taking 3. So this is known as stratified random sampling. This is a table for communicable diseases. Okay, Crimean Congo hemorrhagic fever. The reservoir will be cattle. The vector will be herd tick. The mode of transmission will be the bite of the ticks. Incubation period is 2 to 3 days. Clinical features we will find are fever, joint pain, and bleeding. And case fatality rate is 10 to 40%. For Ebola fever, the reservoir is fruit bats, and the mode of transmission from bat to man will be secretions. From man to man will be body fluids. Incubation period 2 to 21 days. Case fatality rate 50%, and clinical features are the same: fever, joint pain, and bleed. Here it will be the same. For Nipah virus, the reservoir are the fruit bats. If any diagram is given, fruits are there, bats are there, so it is Nipah virus. Okay, and mode of transmission again same: bat to man it will be secretions, man to man will be body fluids. Incubation period 4 to 14 days. Clinical features here will be acute encephalitis, and the case fatality rate is very high, 40 to 75%. For Zika virus, the vector is Aedes mosquito. Mode of transmission obviously mosquito bite. Incubation period 3 to 14 days. Clinical features are fever, rash, conjunctivitis, and in pregnancy we will find microcephaly, small head. Case fatality rate 10 to 15%. For hantavirus, the reservoir is rodent. Mode of transmission rodent with through the rodent feces or urine. Incubation period 1 to 8 weeks. The clinical features will be respiratory failure, renal failure. For MERS, the reservoir is camel. Mode of transmission is from man to man, and incubation period 5 to 6 days. What the clinical feature? It will be acute respiratory failure. It is for MERS. Abhiyan Indradhanush, it is to promote sanitation in ESI hospitals. Colored bed sheets are changed every day. The color will be during the color of a rainbow. So Indradhanush, Abhiyan Indradhanush. Ayushman Bharat scheme is set up health and wellness centers. What are the targets? To provide health insurance up to 5 lakh per family. PMJOY. Antara, one dose 150 milligram of DMPA to be given every 3 months intramuscularly. What is the antiretroviral therapy in HIV patient? TLD is preferred more than TLE. TLD means tenofovir lamivudine dolutegravir. And E was efavirenz. So TLD now is more preferred than TLE. TLD means tenofovir lamivudine and dolutegravir. Chaya pills, centchroman, non-hormonal pills to be taken twice a week for the first 3 months and then once per week after that. So first we have to take twice per week for the first 3 months, then once per week after that. It is a non-hormonal pill. And it is a OCP, oral contraceptive pills, non-steroidal. EVIN, it is to provide info on vaccine stocks, flows, and maintain temperature of vaccines across the cold chains. What are the ESI benefits? Sickness benefit is for 91 days, extended sickness benefit for 2 years, and maturity benefit for 26 weeks. Extended benefit 2 years is given for chronic diseases. What are free days? Sanitary pads under menstrual hygiene scheme are distributed to rural adolescent at the rate of rupees 6 for a pack of 6 napkins, means 1 napkin for 1 rupees. Mission Indradhanush, so it is different from Abhiyan Indradhanush. Abhiyan Indradhanush were colored bedsheets will be changed every day in ESI hospitals to promote sanitation. But Mission Indradhanush will cover 12 diseases. Earlier it was covering 7, now 12. So the diseases are childhood TB, diphtheria, pertussis, tetanus, polio, hepatitis B, pneumonia, meningitis, measles, rubella, Japanese encephalitis, and rotavirus diarrhea. So all these 12 diseases you have to remember. This comes under Mission Indradhanush. Indian Newborn Action Plan, INAP. What is the target of Indian Newborn Action Plan? To achieve single-digit neonatal mortality rate and stillbirth by 2030. Anemia Mukt Bharat, the logo can be given, and it will be asked the weekly iron folic acid tablets, the dose is 60 milligram elemental iron plus 500 microgram of folic acid. The color of folic acid tablet will be blue tablet. Janani Shishu Suraksha Karyakram, it will be free services for pregnant and sick infants. Kaya Kalp is to provide sanitation in public spaces. Lakshya scheme to improve labor room quality at community health centers, district hospitals, and medical colleges. Monica is a WHO project, World Health Organization, to monitor trends and determinants of cardiovascular disease. Midday meal scheme comes under Ministry of Education, and it includes that the midday meal should include 1/3 part of calorie and half protein requirement. NSSK, Navyat Shishu Suraksha Karyakram, is to train medical officer and ANM for basic newborn care and resuscitation to address birth issues, prevention of hypothermia, prevention of infection, early initiation of breastfeeding, and basic newborn resuscitation. Nikshai is a website for online notification of TB. Suman, the full form is Surakshit Matritva Ashwasan, is to provide free health services to all the pregnant women, newborn, and mothers up to 6 months of delivery. Zero tolerance for denial of services. Okay, if there is any denial of services at anywhere for this pregnant women, newborn, and mothers, it also mentions, Suman mentions that there should be zero tolerance. SPURS is to create awareness for leprosy. Now coming to various fertility indicators. You again have to remember these definitions. It will be helpful for your numericals. I have given the formulas also. What is crude birth rate? Crude birth rate is the simplest measure of fertility. It is the number of live births per 1000 mid-year population. So what is the formula? Live births by mid-year population into 1000. General fertility rate, number of live births per 1000 women in reproductive age. And it is a better measure than crude birth rate. What is the formula? Live birth by reproductive women, not the mid-year population, into 1000. Total fertility rate is the average number of children and women can have through her reproductive years. So a woman through her full reproductive year, the average number of children she can bear is the total fertility rate, and it indicates the magnitude of complete family size. Complete family size means the number of children a woman can bear through her complete reproductive years. This is not total fertility rate. Gross reproductive rate, average number of girls that could be born to a woman throughout her reproductive span during her full reproductive span, assuming that there is no mortality, no death of any child. So total number of the girls, gross reproductive rate. Net reproductive rate is the number of daughters a newborn girl will bear during her lifetime. it assuming both fertility and mortality patterns. Okay, it means a newborn girl who is like a girl who is recently born, how many how many daughters this girl will born like bear throughout her lifetime is the measure of net reproductive rate. It is the best indicator of fertility. What is couple protection rate? It indicates prevalence of contraceptive practice, and couple protection rate should be 60% and more to achieve a NRR of 1. So to achieve NRR of 1, net reproductive rate of 1, the couple protection rate should be 60% or more. Vitamins is very important. You can refer to my biochem video and notes to understand all the vitamin and vitamin deficiency or toxicity related diseases. Vitamin is very important. 2 to 3 questions may come in PSM and biochemistry also. So please refer to vitamins from my biochemistry videos and notes. Now coming to the various disease and the toxins and the adulterants. So lathyrism, it causes spastic paralysis. The toxin here is beta oxalyl aminoalanine. The short form is BOAA. What is the adulterant mixed in that? The adulterant is Kesridal, Lathyrus sativus. And how to prevent? With the help of vitamin C prophylaxis. We have to remove the toxin by steeping or parboiling. The next disease is epidemic dropsy. The clinical features will be pedal edema, cardiac failure, and glaucoma. What is the toxin? Sanguinarine. Adulterant, argemone oil, which is added to mustard oil. How will you detect? With the help of nitric acid test. Nitric acid test is the most common test which is done to detect. And the most sensitive is paper chromatography. Most common is nitric acid, most sensitive is paper chromatography. Endemic ascites, the clinical features will be jaundice and ascites. The toxin is pyrrolizidine alkaloids and it is hepatotoxic. What is the adulterant? It is Crotalaria seeds, also known as Junjunia. And how will you prevent? With the help of de-weeding. We have to de-weed the alpha toxicosis. It is actually storage fungus and the toxin is aflatoxin. It is also hepatotoxic. What is the adulterant? It is Aspergillus flavus or parasiticus, and we have to avoid moisture and do proper storage to prevent this storage fungus. This is the only way of prevention. Ergotism, acute, the clinical features will be nausea and vomiting, and for chronic ergotism, the clinical feature is vasoconstriction. What is the toxin? Clavin. Adulterant, Claviceps purpura, which is found in the bajra seeds. How to prevent? We have to float the seeds in salt water, 20% salt water. Then we can prevent this thing. Coming to anemia Mukt Bharat, for children less than 6 to 59 months of age, bi-weekly it is given 1 ml of iron folic acid syrup bi-weekly, and 1 ml contains 20 milligram elemental iron and 100 gram of folic acid. For children aged 5 to 10 years, weekly it is given. It contains 45 milligram elemental iron and 400 microgram of folic acid. The color will be pink tablet. Here before 5 years it was given in syrup form. Here it is folic acid tablet. Okay, here it is given in tablet. It is a pink tablet. For adolescents 10 to 19 years, weekly it is given 60 milligram elemental iron and 500 milligram of folic acid. You have to remember all these doses and when it is given, weekly, bi-weekly, everything. Here the color of the tablet, folic acid tablet, is blue tablet. Within school, boys and girls should be given weekly iron folic acid supplementation, and out of school, only girls should be given at Anganwadi centers. For pregnant lady, it is again important. Daily IFA is given 60 milligram elemental iron and 500 microgram of folic acid. It is a red tablet. And 6 months from second trimester and 6 months after delivery. So when we have to do what is the duration? So from second trimester, okay, 6 months from second trimester, and after delivery 6 months we have to continue. This is the thing included in Anemia Mukt Bharat. For reproductive women, we have to give weekly IFA. It contains 60 milligram elemental iron and 500 microgram of folic acid. It is a red tablet and it will prevent neural tube defects. What is the age for reproductive women? 20 to 49 years. So 20 to 49 years aged women who are in the reproductive age should be given weekly IFA to prevent neural tube defects. Coming to occupational disease, silicosis is the most common occupational disease. In mica mines, those who work in mica mines, it has a risk factor for tuberculosis. How to prevent? Dust control, and it is notifiable under the Factory Act. Asbestosis, crocodylite type, it is the most dangerous and it can cause mesothelioma. It is found in workers who work in the cement and glass industries. Anthracosis in the coal industries, biocinosis from textile mills, cotton spinners are affected more. Bagasosis, it is occurring from the sugarcane waste, cardboard or paper industry. Agent is thermoactinomyces. How will you prevent? With the help of 2% propionic acid. Since we can prevent this, it is not notifiable under the Factory Act. You have to remember that bagasosis is not notifiable under the Factory Act. This is biomedical waste management chart. Cytotoxic waste comes under black color. It includes expiry medicine, radioactive waste, biomedical waste bags, anatomical waste, discarded medications, all these. The most important are the green, red, yellow, blue and white. Next, okay, black is not that important. So green includes recyclable waste like office stationery paper, kitchen waste, disposable paper cups, all these things. Red includes syringe without needles, okay. If needles are there, and is white. Sharp waste or infectious waste without needle syringe comes under red. Catheters, gloves, goggles, urine bag, all the plastic things. Dialysis kit, IV bottles, IV set. Yellow is biohazard infectious waste. Here red was plastic waste, infectious plastic waste. Here it is infectious waste like the pathological waste, cotton waste, gauze, body fluid, contaminated paper and cloth, face mask, cap, bleeding, bedding. Now sharp waste, infectious sharp waste comes under blue, glass bottles, lab slides, infectious vials, metallic body implants, nails, scissors, all these things. And injurious sharp waste comes under white, used needles, used scalpel blades, lancets, broken glass slides, all these things. But syringe without needle comes under red. So just go through this chart once, you will understand, and do some questions from biomedical waste management. Now coming to various image based questions, all the logos. So this logo is for the National Health Mission, Rashtriya Swasth Mission. It combines National Rural Health Mission and National Urban Health Mission. It is under the Ministry of Health and Family Welfare. What are the targets to achieve? Maternal mortality rate less than 100 per lakh live births, IMR less than 25 per 1000 live births, and TFR 2.1. National Tuberculosis Elimination Program, TB Harega, Desh Jitega. This is the logo, TB Mukt Bharat. Here you can find the lungs. It is the new name for revised National TB Control Program, and it will treat category 1 and 2 with the same regimen, HRJD. HRJD means isoniazid, rifampicin, pyrazinamide and ethambutol. 2 months intensive phase plus 4 months continuous phase with the help of HRD. JD is not here. National Tuberculosis Program, NTP, DOTS, Pura course, Pakka Ilaj. DOTS, the full form is Directly Observed Treatment Short Course. Patient will get 500 per month in cash. Chest X-ray and Sibinet are the methods for diagnosis, and daily regimen and fixed dose combination, active case finding. Also, it will do treatment for the drug-resistant TB. This is a mobile app, Nikshay. This is the logo for this app, and it is an online tool for monitoring and surveillance of TB control program. Janani Shishu Suraksha Karyakram, this is the logo for that. What are the components? Free diagnostic, free drugs, free delivery, free diet, free blood transfusion and free delivery. Okay, free delivery means delivery in the hospital. Newborn care center, newborn stabilization unit, special newborn care unit, home-based newborn care, all these are included in Janani Shishu Suraksha Karyakram. National Vector-Borne Disease Control Program, NVB-DCP. Here you will find a mosquito. The whole family, mother, father and child, and a mosquito will be there. So it is National Vector-Borne Disease Control Program. Most common vector-borne disease is malaria. What are the which diseases the program includes? It includes malaria, dengue, filariasis, kala-azar and Japanese encephalitis. Then this logo is for National Program for Prevention and Control for Cancer, Diabetes and Cardiovascular Disease and Stroke. These flowers will be there. By this you can understand it will be for health promotion, opportunistic screening, referral, diagnosis and management of non-communicable diseases. This was vector-borne diseases. This is for non-communicable diseases like cancer, cardiovascular disease and stroke. This is the logo for Suraksha Clinic, which is a sexual and reproductive health service. Here are the various kit numbers. So kit 1, 2, 3, 4, 5, 6, 7 are given. Kit 1 is grey in color. It will it is helpful for diseases like cervicitis, urethral discharge or anorectal discharge. It is used for the treatment for this disease. Kit 2 is green in color. It is used to treat vaginitis. Kit 3 is white in color for genital ulcer and non-herpetic genital ulcer, okay, which responds to penicillin. So this is for non-herpetic genital ulcer which will respond to penicillin. Kit 4 is blue in color. It is for non-herpetic genital ulcer which is allergic to penicillin. Kit 5, which is red in color, is for genital ulcers which are herpetic. These two are non-herpetic. This is herpetic. Kit 6 is yellow in color. It is for lower abdominal pain. And Kit 7 is black in color for inguinal bubo. This logo is for National Program for Control of Blindness. Blindness, what is the definition? If the vision is less than 3/60 in best eye with best possible correction. So whatever possible best treatment we have given, and in the best eye the vision is less than 3/60. What is the most common cause? It is cataract. And what are the target? To eliminate all causes of avoidable blindness. What are the causes of avoidable blindness? Cataract, glaucoma, childhood blindness, trachoma, diabetic retinopathy, and corneal blindness. In school there should be one teacher for 150 students for screening of vision. This is the logo for ESIC, Employees State Insurance Act 1940. It was established under the Ministry of Labor. What is the contribution for employer? 3.2% of the wages. An employee should give 0.75% of the wages, ESIC. Next comes Ujjwala Unnati Jyoti for affordable LEDs for all. It is under the Ministry of Power, Government of India, and it includes distribution of LEDs at affordable and subsidized prices. Vaccine vial monitoring, we have already discussed what is the idea behind this, and these are the various images. This will be on the various vaccines. These are the symbols. We have to understand what does it mean. So if the inner square is lighter, here the inner square is white, outer circle is blue. Inner square is lighter in color than the outer circle. It means that the expiry date has not passed. We can use the vaccine. It comes under stage 1. Stage 1 and 2 can be used. Here, as the time passes, the inner square is still lighter than the outer circle if the expiry date has not passed. Okay, again we can use the vaccine. Now stage 3 and stage 4 we have to discard. What does stage 3 means? Discard point. The color of the inner square matches that of the outer circle. Here the color, we cannot find the inner square anymore. The color has matched, so we cannot use the vaccine. And here in stage 4, the beyond the discard point, inner square is darker than the outer circle. Here it is darker in color than the outer circle. We cannot use the vaccine. So this is the vaccine vial monitoring. These images might come. Coming to various international organizations, so we will understand, we will remember these by the help of the headquarters. So the headquarters which are located in Geneva, Switzerland are WHO, International Red Cross, UNAIDS, and International Labour Organization. Their all headquarters are located in Geneva, Switzerland. WHO was started in 7th April, World Health Organization. This is the logo. You have to remember the logo, the headquarter. Started on 7th April 1948. Therefore, 7th April is known as WHO Day. This is the logo for International Red Cross. It provides humanitarian services. Also, it provides services to the sufferers of natural disasters like for war or earthquake. UNAIDS for HIV and AIDS, and International Labour Organization. It will help improve working and living conditions of working population for all the labours all over the world. Now coming to the headquarters which are located in Newark. It is UNICEF and UNDP. So UNICEF is a UN agency which is focused on providing humanitarian and development aid to children worldwide. It was originally known as the United Nations International Children's Emergency Fund. It was established in 1946. Why? To support the children and mothers who were affected in the World War II. UNDP, it helps countries to eliminate poverty and achieve sustainable economic growth and human development. Also UNFPA, this headquarters is also located in New York. United Nations Population Fund, the full form is United Nations Population Fund. It is the UN Sexual and Reproductive Health Agency which is focused on delivering a world where every pregnancy is wanted, every childbirth is safe, and every young person's potential is fulfilled. Next comes the World Bank and USAID. Their headquarters is in Washington, USA. The World Bank is an international financial institution, provides loans and grants to the government of low and middle income countries. It will provide loans to the countries who are low and middle income. USAID, it is a help from the American people. So the United States Agency for International Development was an independent agency of United States government that was responsible for administering civilian foreign aid and development assistance from 1961 to 2025. SIDA, Swedish International Development Cooperation Agency, it is used for tuberculosis. The headquarters is in Stockholm, Sweden. S for Stockholm, Sweden. DANIDA, this question came in the January exam. It is for blindness, Danish International Development Agency. The headquarters is Denmark. You have to remember all the logos, their headquarters, and what is the agency responsible for. Next, some few very important topics. I have kept it at the last because questions will definitely come from these topics. So for rabies, how will you do pre-exposure prophylaxis? Means before the dog has bitten, how will you treat that? So first we will do the pre-exposure prophylaxis before the exposure, okay, before the dog bite has occurred. So it is also known as primary level of prevention, and it is given on, the injection is given on 0, 7, 21 or 28 days. It is given intramuscularly, and to achieve goal, what is the goal? To achieve antibodies more than 0.5 international units per ml, and we have to repeat booster dose every 2 years. Post exposure, how will you treat? Now, if it was previously vaccinated within 3 months, then no vaccine or immunoglobulin is needed. If it was vaccinated 3 months to between 2 years, if between this time frame the person was vaccinated, then only booster dose should be given. If the person was vaccinated beyond 2 years, then we have to provide the full schedule. And if the person was non-vaccinated, there are 3 regimens by which we can provide the vaccines. The first one is SN regimen. Here intramuscularly vaccine is given 0, 3, 7, 14 and 28. So these are the days when we provide intramuscular vaccine. Thai Red Cross regimen, intradermal, and it is the best route because it is easily absorbable. Vaccines are given on 0, 3, 7, 4, 14 and 28. 14 and 28. And the sites on, so these are the days, okay, 0, 3, 7, 14 and 28, and these are the sites. So on 0 day the vaccine will be given on 2 sites, on 3rd day 2 sites, like that. And Zagreb regimen, 0, 3, 7, 14 and 28, these are the days, and these are the ampules, not the sites. Here it was the site, here it is the ampules. When 2 ampules will be given, 1 ampule will be given, so these are the ampules. HIV prevention from parents to child transmission. How will you prevent HIV from parent to child? Suppose if the mother is a known case of HIV and on ART, already on ART, so we will continue it in the pregnancy, continue in first trimester also. And if the mother was diagnosed during ANC screening, antenatal checkup screening, then we will start the antiretroviral therapy as soon as possible. For newborns, what we will do? So for newborns, we will start as soon as possible in 72 hours, but best if we start in 2 hours. If the mother was on ART during pregnancy and the mother was sufficient, okay, the prevention was sufficient, like the mother was taking the antiretroviral therapy for more than 4 weeks, then we have to give nevirapine for 6 weeks, and also we can give nevirapine, then we can give zidovudine for 6 weeks. If the mother was insufficient or no ART was taken, then we have to check for the risk of transmission. If the mother is a low risk of transmission, means the viral copy is found to be less than 1000, then, or the mother is on high risk, viral copy is more than 1000, then we have to give nevirapine plus zidovudine, and we have to look for like the type of feeding the mother is doing to the child. If the mother is doing breastfeed, we have to give it for 12 weeks, and if the mother is giving any other type of feed, we have to give it for, continue it for 6 weeks. This is the logo for prevention from parents to child transmission, prevention of HIV from parents to child. This is the logo for it. Contraception you have to study from OBGYN, okay, full contraception you have to study from there. Healthcare system, this is the healthcare system of India. It is divided into the following parts. The following the following people will take care of it. ASHA, the ASHA workers work in the village. Population is 1 per 1000, so 1 ASHA worker per 1000 population. 23 days training is required to be a ASHA worker, and the ASHA workers is part of NHM, okay. She should be a member of the village only. She should be a resident of that particular village only where she is working, and she is part of the National Health Mission, and also JSY, Janani Suraksha Yojana. The aim is to promotion of hospital delivery and home delivery of condoms, OCPs. All these functions ASHA workers does. Active disease surveillance also. What are the disease surveillance the ASHA worker does? Active disease surveillance, TB, leprosy, filariasis and leishmaniasis, and also home-based newborn care. If the child is a home delivered, day 1, 3, 7, 14, 21, 28 and 42. All these days the ASHA worker will visit the home. And for hospital delivery, since the mother is discharged from the hospital after 48 hours, then from 3rd day, the ASHA worker will start visit the home. Day 1 will not visit, day 2 will not visit, day 3, 7, 14, 21, 28, 42. Anganwadi works at the ICDS center. The population for plain areas will be 1 Anganwadi per 400 to 800 population, and 1 per 300 to 800 population in the hilly areas. Eligibility should be 12 plus. Who are the beneficiaries? 0 to 6 years children, mother who are pregnant or lactating, adolescent girl 10 to 19 years of age, and reproductive age women. Functions: growth, immunization, midday meal, referral service and health education. Multipurpose worker female works in the MCH care. they conduction of delivery at the sub centers or at home. Also they do TD vaccination, IFA tablet, IUCD insertion. The lowest center is sub center. For IUCD insertion, the lowest center is sub center. Antenatal, they do antenatal visit, they do postnatal visit, they do identification for the cases of MTP or tubal ligation, and for tubal ligation the lowest center is PHC, primary health center. Also they conduct tests for hemoglobin, blood sugar or urine to albumin ratio. Multi-purpose worker male, they will do the treatment of common diseases, they will do immunization. Also the most important thing they will do is this one, chlorination of well water. Also they will do active malaria surveillance. These two may come in your question. They are part of the IMNCI program. What is IMNCI? Integrated Management of Neonatal and Child Health. Also they will give contraceptive advice, sputum collection for suspected TB cases, and they will transfer those sputum to the DMC. DMC is designated microscopic center. So sputum collection for TB cases is important, chlorination of well water is important, and active malaria surveillance is important. Medical officer MO, they are in charge of the PHC. They will do treatment of common diseases. School health check they will do every 6 months. Minor surgery under local anesthesia they will do. What are those minor surgeries? Epistemotropy repair, incision and drainage of abscess, wound repair, all this they will do. Training of staff also they will perform. They will conduct meeting of staff members once a month, and they will supervise all the national programs at the PHC levels. Health assistant male or female, they will supervise the work of multipurpose worker male or female. Once a week they will visit the respective sub center, and they should also randomly visit 10% of the houses. They are also in charge of the record maintenance. So these were all the high-level topics for your PSM. You can expect more than 30 questions in your FMG and NEET PG exam. All the logos you have to remember, all the health missions you have to remember. Contraception, study from the OBGYN portion. Vitamins, it is must, you can study from my biochemistry notes. All the one-liners, the exams, the FMG exam is now more focused on one-liner. In the previous exam you have already seen. So all the one-liners are covered here. All the missions here are covered here. The communicable disease, the vectors, here I have discussed the statistics, what is sensitivity, specificity, PPV, NPV, false negative, false positive, all the formulas we have discussed, what is case control study, cohort study, what are the indicators of the quality of life, morbidity and mortality indicators, everything is completely discussed. And the most important thing is the vaccination schedule. So the vaccination schedule I have to revise at least once before going to the exam hall. On the morning before going to the exam hall, revise this once. And this PDF, if you revise more than 3 times, it's enough. Like more than 3 times, you have to at least revise, and you shouldn't miss any point from these 11 pages. Thank you.